Okay, so we'll start with setting up an efficient cardiac CT service and also talk about how we prepare the patient for the cardiac CTs. So we'll go through the service setup in terms of what staff is involved, in terms of equipment, in terms of what kind of patients we need to get the best quality images. We'll look at how the workflow for cardiac CT work, and also then go through the different aspects of preparing the patient with drugs, etc. So a good service depends upon staff at various levels and also a right equipment to have in the department. And this is a new latest guidance that is still online, not published yet, about performance and acquisition of coronary CT. On the SCCT website, you can access it from, but I have also put this document on the OneDrive folder, so you can read this, go through this. Some of the information that I'm going to give you on this talk is from this particular document. So in terms of the doctors, in terms of radiologists and cardiologists, so ideally if you're running a service, you need at least 2 or 3 cardiologists or radiologists, ideally combination of both, who are at least level 2 trained in cardiac CT to run the service. You have to be obviously continue to update yourself in terms of latest guidelines, what research is coming out, and audit your performance in terms of your diagnostic accuracy, in terms of your radiation dose, for example. It's very important. Whoever is the lead of the service, if you have a lead, then you would be involved in writing up and developing new protocols. You will be responsible for maintaining the image quality, quality of the reporting that you're producing, then optimizing the radiation dose, etc. And you're also responsible for motivating rest of your colleagues, both among the doctors as well as among the radiographic staff. Again, you need 2 or 3 radiographers to run the service. So initially, obviously, one radiographer gets trained, and that person trains second one, and then third one. Like that, you develop a team of 3 to 4 radiographers which would be required to run the service. Normally, the radiographers would get training mostly from the apps specialists, who come from the company. When you either buy a new scanner or you are developing a new service, you can call them, and they will train the radiographers as well as show us the doctors as well how the scanner does the cardiac CT scans. The radiographers can also go attend courses like how you have come here, or they can go to other sites performing cardiac CT to learn how that particular scanner cardiac CT is performed. Now, they are very important in terms of developing the protocols and optimizing radiation dose, because they are the ones who are actually doing the scans. Their buyback is very important. Their buy-in to the whole service is very important, because unless you have a team of motivated radiographers, then you're not going to get the scans done in the first place. So they should be able to review the image as soon as it is produced and troubleshoot if there is any ECG editing to be done. If something has been cut off from the top or bottom of the heart, for example, they need to be able to check it and come and show us what's happening, so that we can review if the scan has to be repeated at the same time before the patient leaves. So a teamwork with the radiographers is very, very important for this service. Then again, booking staff and the secretaries are important, in the sense that when the booking staff calls the patient, they will go through, at least in our hospital, they go through a set of questions with them regarding their renal function, regarding the allergies they might have, etc. And they would give some basic advice. For example, they know, to check for renal function and what to say to the patient. And if something complex, and they will come and ask us that what should we advise the patient if patient's EGFR is so much. So that kind of basic training they have been given, and that really helps to reduce the number of times patient comes ill-prepared for the scan. And then secretaries are important in terms of dispatching the reports in a timely manner. In terms of equipment, we need at least 64-slice CT scanner with ECG-gating hardware on it. So that's the crucial bit. Not all 64-slice scanner would have the ECG-gating hardware, so that's important to do any cardiac CT. Then now to have a less or low radiation dose, the scanner should have the capability of doing prospective scanning, should have capability of scanning at 100 or even 80 kbp, and ability to do retributive reconstruction. So these have become quite essential now if you are setting up a new service. Then any injector will do, but ideally, if you want some contrast in the right side of the heart, you need a dual-headed injector with the facility to mix the contrast and saline in the second phase of injection. So normally, a lot of people would just inject contrast followed by saline, and that can be performed by single-headed injector or dual-headed injector. But to mix the contrast, you need a dual-headed injector with the facility to mix contrast in the second phase, and that enhances the quality of your scan as well. Then third thing in terms of equipment is having the right kind of advanced post-processing cardiac CT software. So when we purchase any CT scanner and you specify you want cardiac software on it as well, most of the vendors have their own specific version of the CT software, like how you are working on here, like Vitria. So these software, they can be thick client or thin client. So thick client are the ones that sit on the workstation based completely workstation, while thin client are the ones that are sitting on the server in somewhere in the hospital, and you can access them through any of the PCs in the department or the hospital. So they are called the thin client ones. So now majority of the vendors now they're moving on to thin client systems, and you need multiple licenses depending upon how many of you would be using the software. So any good software should be able to do MPRs of different kinds, like how you have been saying. They should have ideally some tools to be able to quantify the degree of stenosis, be able to do plaque analysis, and quantify chamber size, volumes, etc., function if you've got retrospective data. And there's now specific specialist softwares for TAVI assessment as well, so they can measure the size of aortic annulus, aortic root, etc., automatically. So that's a high-end part of the cardiac CT software. Then it's a must to have some device to measure the heart rate and blood pressure of the patient. So before the patient goes in the scanner, we have to determine what drugs to give, ensure patient's heart rate is low, below 65 or 60, and you need monitor to, if required, afterwards also. If patient's heart rate goes too low or patient faints in the scanner or something happens, you need some sort of a monitoring device there. In terms of drugs, the most commonly used drug is the metoprolol. So we normally keep both oral tablets of metoprolol as well injectable is intravenous ampules, and some sites also would use ivabradine in patients where the metoprolol is contraindicated. Then we need GTN spray for vasodilation, and obviously we need resus trolley, which should be part of any CT scanning service. So how the whole process works. So there are 4 aspects of the cardiac CT workflow, and that's probably true for any CT scan we do. So first aspect is justification of the cardiac CT request. So this we do under the IRMA regulations. So we have to look at the request form or request letter, and then evaluate the clinical information that has been is given, whether the scan is required or not. It's appropriate to do the cardiac CT on this patient or not. And if it's justified, then we decide on the protocol, roughly what protocol this scan will require. And if there are any obvious contraindications on the request, then we highlight that, and we might have to take any precautions to mitigate any risks. For example, like sometimes I see there are, it would mention on that patient has got serious allergy to intravenous contrast, and they're asking for a cardiac angiogram. So that's a bit I think, naughty to request a coronary CTA if you know patient has had serious allergy or serious reaction to contrast media. But it's good information, because what we can do is we can call the patient, or we can ask the referring cardiologist to prescribe steroids, oral steroids to the patient beforehand, from a day before or something, so patient comes prepared. Or we can give some intravenous hydrocortisone before the scan starts. So there are certain things that one can be prepared for if we know if we know there are any contraindications to the drugs we're going to give. So then second aspect is the appointment letter that goes out to the patient. Again, at the time, the staff will go through all the different contraindications for the procedure. They will be able to give some answers to answer the queries of the patients. If they cannot answer the queries, they will bring the request to us to ask what they should do. In terms of patient preparation, we ask the patients to continue to take fluids, oral fluids, except they should not drink any caffeinated drinks. So no tea, coffee, or any other caffeine drinks for at least 3 to 4 hours before the procedure. But they should take their medications as normal. So normally you can scan 2 to 3 patients per hour. So initially when you start your service, you will probably scan 2 patients an hour, so half an hour each patient. But once the whole workflow is all smooth, then you can scan up to 3 patients for CT coronary angiograms per hour. So we ask the patient to come about 30 minutes to an hour before the procedure. If we are giving oral beta blockers, then we ask them to come an hour. If we're giving intravenous, then they can come 20 minutes to half an hour before the actual appointment time. So when the patient comes to the department, so important thing is they have to be reassured, they have to be relaxed, because they're quite anxious. They're coming for a coronary scan. They have been told they might have, coronary blockages, etc., etc. So the staff who meets them, it's very important that they are easing their anxiety at the time. So explaining the procedure properly is very important aspect. And then they assess, is this the right patient for scanning? Is the patient too large? Now, what is too large? It's a very relative thing. We have scanned patients up to 150, 160 kilograms body weight, but anything beyond that, probably the scan would be not of good quality at all. Do they have any contraindications to beta blockers? And I will come to the contraindications, but that again, if there are some serious contraindications, then you may not be able to, you will still be able to scan with retrospective gating, or you can give them other drugs. You can try other drugs in those cases. Irregular rhythm, if patient is an AF, for example, are you going to get good image quality from your scanner? That's very variable. So each scanner behaves slightly differently with patients with AF. So you definitely do not want patients with proper AF. If they're controlled AF, then that's fine. You probably would get away with reasonable quality. The biggest problem is patients who are not able to lie flat on the scanner table and are not able to put the arms up, because they have to raise the arms up. If the arms are down like this by the side of the heart, then you will get lots of artifact from the bone here. So the scan will be non-diagnostic. Then lastly, again, that will become probably absolute contraindication if they're not able to hold their breath. So breath holding is required for about 10 seconds during the scan. So if you can't hold their breath for 10 seconds for any reason, then they would not be able to go through the scan properly. So after determining that this patient is suitable for the scan, so the radiographers would go through this questionnaire, which is probably in your manual. So the first part of the questionnaire is about the symptoms, what symptoms they have, and the second part is about their risk factors, which is not determining whether we do the scan or not, but this is just to get information about their clinical aspects and risk factors. So if the scan is just for calcium scoring, then we don't have to measure the heart rate or the blood pressure or contraindications to beta blockers. Then we can just carry on and do the scan if it's just for calcium score. If it's for a coronary angiogram as well, then we have to ensure that we know the heart rate what the heart rate of the patient is, and it is below 60 beats a minute, or whatever the cutoff value for your particular scanner is. So this cutoff value of 60 depends upon the scanner to scanner. But most scanners, it is still 60. Some are now able to scan prospectively with a heart rate of 65 or even 70. So the purpose of reducing the heart rate is to obtain good image quality with least motion, and second is to allow prospective ECG-gating, because you are lengthening the diastolic phase of cardiac cycle, and hence lower radiation dose. So once the heart rate is more than 60, then we check for the contraindications to the beta blockers. And asthma, again, we have seen that patients with mild to moderate asthma, beta blockers are not a problem. So I always check, have they been admitted with asthma, acute episode of asthma to the hospital? If they have, then I would not give beta blockers. But if they have not, I have given quite high doses of beta blockers to these patients without any problems. So again, this is something that you have to feel comfortable in your own practice and give the beta blockers slowly, so that there is no adverse reaction. So patients with severe heart failure, severe aortic valve stenosis, so patients coming for TAVI assessment, we do not give them any beta blockers. Or obstructive.
Severe heart failure, sorry. I understand not in acute pulmonary edema, but all patients with severely impacted function having beta blockers, of course.
But to what extent though?
Near class 4.
10 grams.
Patients congested.
To what extent? How much beta blocker will you give to a patient with heart failure?
Only in acute, if the patient is in acute heart failure, we don't give for it.
Not in acute.
Yeah, chronic heart failure.
So chronic heart failure, what's the dose will you give?
Maximum.
Maximum.
What's the maximum dose for you?
That's tolerated.
10 milligrams
Tolerated.
Talking about
10
metoprolol,
10 milligrams bisoprolol. Okay. So I don't know how bisoprolol dose equates to the metoprolol, but we have to give up to 40 milligrams of metoprolol to reduce the heart rate. So if you think you're comfortable giving that to a patient with heart failure, then fair enough. Fine, go ahead and give it. So you have to titrate the dose depending upon your patient. And as a cardiologist, you might be able to do that, but if you are talking to a radiologist who is looking after the patient in the scan, then they may not be comfortable. So it just depends who it is, who the patient is, and who you are. What is your level of comfort? But these are general contraindications too.
This is meaning chronic, not acute, of course.
Yes, chronic. Yes. For acute, you would not use anyway. Yes.
Doctor, I may just suggest that you write your IV beta blockers.
No, even oral. So oral, we give 100 milligrams oral metoprolol, 100 to 150. So I'll come to doses, and then you can decide what you want to do with your patients. So this is the bottom part of the questionnaire. So the radiographers will measure the patient's heart rate, blood pressure, and they would then go through the contraindications of beta blockers, because a lot of it is driven by the radiographers. We give them the freedom, the responsibility to get all this information for us, and then we decide as doctors what's right for this patient. Nothing is absolute here. There's no absolute contraindication. And then they will measure patient's height, weight, calculate the BMI. So with this information, they will come to us with the questionnaire, the performer, and then we will decide as to what's the dose of beta blocker we have to give, whether we have to give GTN or not, for example, and what's the protocol we have to use, what's the KVP we use, KVP and the gating we use. So based on the clinical information that's required on the request form, based on the presence or absence of contraindications to beta blocking or GTN, and based on patient's body size. So all these factors determine what drugs we use, what protocols we use. So now coming to beta blockers themselves, so some people would just use oral beta blockade. They will not give intravenous at all. So that's one way of doing it. Second way is using oral beta blocking to the maximum. Then in those patients who don't respond to oral beta blockers, then you give intravenous to supplement the oral beta blocking. And third way is just purely give intravenous only. So that's the one that I think I like personally, my preference, but there are people who just use intravenous only and they are very happy with that either. In terms of effectiveness, both the second and third ways are equally effective, but what you choose depends upon what your personal situation is in your own department, what's more convenient. So the way the second one works, the oral followed by intravenous, is this is how I used to do. Now we have moved to pure intravenous, but this is how we used to do till last year. So if there are no contraindications, then we start with 1 tablet of 50 milligrams of metoprolol orally. If they are bigger patients, 100 kilograms or more, then I would give them 2 tablets, 100 milligrams to start with. Then wait for 30 minutes, check their heart rate. If it is still more than 60, then I give them another 50 milligrams. Then wait for 15 to 20 minutes of the second dose, and then put them on the scanner and check their heart rate again. Do the calcium scoring, check the heart rate again. If it is fine, if it is come down to 60, then do the scan. If it is still more than 60 or 65, then you give them top up with IV beta blocker, up to 20 milligrams or something like that, 20 or 30 milligrams. So with this method, I would not have to do anything. Intravenous will be required only in 1 in 5 or 1 in 6 patients. So this is purely done by the radiographers. They do it, everything. I just prescribe it on the performer. If I was to give intravenous, then I would be getting up to do that myself, because the non-medical staff cannot give intravenous beta blockers. We will, as doctors, have to give intravenous beta blockade. So then I have to give up in middle of my reporting. For every 10 minutes, my time will be wasted. And also I feel that when we are giving intravenous beta blockade in the scanner, the scanning time is also being wasted, that 10 to 15 minutes of giving them solely intravenous beta blockade. So it's less efficient, I feel. But in terms of effectiveness, it is equally effective. So other options are only intravenous, and we give up to 40, even 50 milligrams of intravenous metoprolol. So you have to see in your patients what is safe. That's the important thing. If the patients have contraindications to beta blockers, we have tried oral avibradine, but you have to give this 5 milligrams BD for 2 days before the procedure. 5 to 7.5 milligrams for the procedure. Or one can try intravenous calcium channel blockers also to reduce the heart rate. But I know they are not as effective as metoprolol, which is probably the most effective drug. And metoprolol has been shown to be very safe drug, very, very safe drug. Now we scan patients with end-stage lung disease who have got severe end-stage COPD, end-stage pulmonary fibrosis, who are coming for lung transplant assessment. And in the last few months, we have started to give them up to 40 milligrams of intravenous metoprolol. So we are assessing the coronary arteries prior to them going into their transplant waiting list. And so far, touch wood, nothing has happened to any of the patients. So it's just getting the experience of your patient cohort that you have. In terms of nitrates, so as you know, they are required for dilating the coronary arteries and hence getting better image quality. So we normally give 2 puffs of GTN sublingually, about 3 to 4 minutes before we start the CT angiogram. And again, we have to be aware of what the contraindications for nitrates are. So then we finalize the protocol based on patient's heart rate, etc., what we are doing exactly. And we decide in terms of prospective versus retrospective gating. So prospective gating for simple assessing the coronary arteries is the default protocol. If that's what you want to know, does the patient have significant coronary artery disease or not, then you want to do that scan with prospective gating. So unless you can't reduce the patient's heart rate below 60, 65, and the heart rate is variable, there's some degree of arrhythmia, ectopics are coming, or you want to evaluate the cardiac function, you want to look at the valves of the patient, then you may have to do retrospective gating. So the second thing is decide on KVP. So if patient's body size is in terms of BMI is less than 30, and along with the body weight being less than 90, then we would use 100 KVP protocol for that purpose, for that patient. Exception being patients with stents, with bypass grafts, and with lot of calcium in the coronary arteries, we may choose to still do 120 KVP irrespective of their body size, because you want optimal penetration of X-rays through these dense structures. So the thing with 100 kVp is that compared to 120 kVp, it will reduce the radiation dose by half. So it's a massive dose reduction by using 100 kVp. So in terms of reporting, so I try to report all the scans in the same session that I'm doing by the CT angiograms that are being done. So I'm reporting them as soon as they are acquired, immediately after that. Some people, I think, do them differently. They just focus on getting the scans done in terms of the procedures, and then they will sit after in another session, another time, and then they will report it. Both ways are fine. It depends upon how it works in your department. Okay, so in summary, the most important thing is that all the staff are motivated, properly trained. There's a well-defined workflow, how you are moving from one step to another. The protocols should be correctly understood. Again, remembering that you are doing the scans to obtain the information, the diagnostic information, so your image quality should be optimal for it. At the same time, you have to use protocols to minimize the radiation dose. An appropriate heart rate control is must for both purposes, very, very important. And this can only be achieved if your patients are relaxed when they come and when the scan is being done. So very important. Okay, so I have some questions before we have a tea break.